So maybe I can ask the first question I would like to address to Daniel. So the question is from Professor Ashraf. He asks, when we say that vaccination, not vaccine, saves life, then why we continue to call it vaccine hesitancy? Why should we call it a vaccination hesitancy? So Daniel, please.
Thank you, Lillian. First of all, I have to thank the Professor Ong and Professor Ismail for excellent talks. And as this question is vaccine hesitancy or vaccination hesitancy has sparked quite a lot of discussion in the academic field. Mm-hmm. And academic or narrow scope speaking, vaccine hesitancy means only on the production of vaccine and the concept of vaccine. For vaccination is a broader term, is vaccination plus the acceptance. Mm-hmm. But because both of them are quite used interchangeably. Mm-hmm. So for the ease of public health policy, they have decided that the use of vaccine hesitancy is easier for most people, but they can be used interchangeably.
Yeah, and also I think, well, in Hong Kong, because we use both English and Chinese, but in Chinese seems the terminology may not make a very significant difference, right, for both terms.
For Chinese, vaccination hesitancy means quite a long term.
Okay, thank you, Daniel. So the second question I would like to address to Anna, which asks, a previously healthy 45-year-old man suffered from dilated cardiomyopathy with very low EF function, only 30 to 40%, a few months after the COVID vaccination. So in this situation, very clinical, how can we confirm this is a vaccine-related kind of cardiomyopathy or it is idiopathic cardiomyopathy? Anna, please.
That's actually quite a difficult question to answer. And if I may also loop in Professor Zul, being a cardiologist, he may have an opinion after I respond. So typically when we talk about adverse events following immunization, it's very important to determine or rather to understand that having sequence of events, a sequence of events following immunization doesn't necessarily mean that it was the vaccine that caused the problem. Some temporal relationship, there may be, for example, an event that happens immediately after, but it doesn't necessarily mean that the vaccine was the cause of that event. So let me give you a very exaggerated example. So it may happen that right after this webinar, because Dr. Josie is so pleased with the attendance, that she will send each participant of this webinar a dose of flu vaccine, a free dose of flu vaccine, so that we can all be protected against flu. And then right after we take our flu vaccines, we suddenly develop, we grow a strand of blue hair. Okay, so a very ridiculous example. You would probably be very, very hard-pressed to say, oh, that's because of Dr. Josie's flu vaccine. It's not only meant to protect against flu, it's also beautifying because it gave us blue hair. So just because it happened right after the vaccination doesn't necessarily mean that it was because of the vaccine. It could have been something else that caused this particular event from happening. And the only way to really find out whether there is a causal relationship is to be able to compile all of these events in a large-scale surveillance system so that we can have an idea that for every instance where Dr. Josie gave us flu vaccines, everybody developed a strand of blue hair, and therefore it is Dr. Josie's flu vaccine that causes it. So let me extrapolate that now to the question of cardiomyopathy for this 45-year-old male. So number one, the reports of cardiomyopathy, myocarditis following vaccination with COVID vaccines were typically found within a 7-day period after the second dose. of mRNA vaccines for adolescents and young adults. So in this case, there are many uh, features in this case that don't seem to align with what we expect from the typical case of mRNA vaccine associated myocarditis. So we are talking about an older male. The time frame seems to be quite remote. We are not told whether this is a first or a second dose. And it seems like the degree of impairment is quite severe when most of the cases of viral myocarditis, or rather vaccine-associated myocarditis reported after mRNA vaccination were mild and self-limited. So I would encourage the physicians looking at this case to consider other pathologies, other possibilities for the pathogenesis of the AAFI. Professor Zul, if you might have something to add.
Yeah, thank you. I agree with what you've said, most of it. But although we say that most of the myocarditis, I've read all of the articles that came out during that time, and although most of it occurred in my adolescents and young adults, there are also cases among the older generation, but they are less. So it doesn't mean that if the patient had got myocarditis or cardiomyopathy after the vaccination, we cannot dismiss it altogether and say it's not related, number one. Number two, your chance of getting cardiomyopathy from COVID is also higher than your chance of getting, when you look at chance, is higher than if you get it from the vaccine. But we do know that with the messenger RNA vaccines from AstraZeneca, we know that there was higher incidence among the younger population. So we were quite cautious when we wanted to open it to the public here, but the minister decided to open it to everybody who and not in the usual list of vaccines. So the young people were all registering, and we were waiting to see what was happening. And actually, we had very few cardiomyopathy among the youngsters who actually got the vaccine. So I mean, that's all I can say. I think one more thing. We should not be too quick in dismissing it. Because a lot of us and a lot of professionals will actually dismiss it and say, no, it's not related to the vaccine. But people who know that patient and who know what's happened, actually they actually know that this is related. So we can't dismiss it altogether. I mean, that's my personal view.
So thank you, Sue and Anna. I think many times clinical situation is not easy to answer because there's a lot of different factors affecting. Okay, so now we go to the third question, which I think Sue will be the best to answer because you have a lot of experience in those, promoting vaccine initiatives. So the third question is, what are the best way to counter disinformation and public vaccine hesitancy, such as anti-vacciners? So Sue, please.
Thank you. If you have, there is a spectrum, all right? There are people who actually will reject the vaccine altogether. There's the spectrum in the middle where they will reject, but they will accept. Then there's in the middle where they will accept, but they're still a bit hesitant. And then at the other end of the spectrum are people who actually will accept the vaccine no matter what. So these are the what we call the green light. So they will accept the vaccine whatever you tell them, and the other one will not. So you have to be wary of or understand where the person in front of you is coming from. So if that person actually is in the category of will not accept at all, then you explain what you have to explain, and then you tell them that we are open. You can always come back anytime if you feel that you want to know more information. But you don't dismiss them altogether. what many people make is anybody who is hesitant about vaccines, you will tell them as anti-vax. Many times I've walked into the ward and the nurse will say, "Oh, we've got this parent. The baby's just born. They refuse to take hepatitis B. They refuse to take BCG and all that. This one is an anti-vax." So you go in there and you explain and you tell them that why we're giving the vaccine, and then they will still not get it. I mean, I know these sort of people, they will still say no, but at least you have put that seed of doubt in him, and so that when usually I say him because he's usually the father, and the father will go back and then they will think about it. There are two basic things. Number one is never assume that the patient is an anti-vax, right? They are hesitant. They need more information. And we are the people who can give them that information in a factual and non-biased manner. And that's all we can do. We cannot argue with them. We cannot tell them, look, you need to have this. This is mandatory. You can't do that. So all you can do is tell them, and then hopefully they will buy in and listen to you. But when you develop that rapport, they will come back to you. I hope that helps.
Okay. I will move on now to the fourth question, and any of our esteemed speakers can answer. What is the current recommendation regarding COVID-19 boosters, and why is it that healthcare workers' update of these boosters does not reach 100%, and how can hospitals and other healthcare organizations improve on this? Any one of you, please. Thank you.
Maybe I can start off. As a disclaimer, we actually don't have COVID vaccines available anymore in the Philippines. So the last time COVID vaccines were available in our country was 2024, if I'm not mistaken. And after that, no more stocks, no more supplies. So that's actually been quite difficult because the only way we can be protected against currently circulating strains is by exposure. So if you happen to catch the disease, you hope for an unremarkable course and just think about it as being protected. Just think about the disease as having your booster for that course in a way. Now, in other countries, COVID vaccines continue to be available, continue to be recommended on an annual basis. So similar to the flu vaccines, because they are now considered as part of the spectrum of respiratory infections that can be quite severe, especially for particular risk groups like the seniors, pregnant, and young children. So in many temperate country settings, developed country settings, the recommendation is to continue providing these vaccines with an emphasis to recommend for high-risk individuals. Now, for healthcare workers, of course, because of the potential for occupational exposure, we are considered to be a high-risk group. And in fact, when COVID vaccines were available, at least in the Philippines, the healthcare workers were really prioritized. So it's still the same thinking that healthcare workers would be considered part of the risk groups and therefore should be receiving vaccine. Now, as to the question of why it's not 100%, I think it's really a combination of factors. There are people who don't feel that it has value. We have to accept that. And for that particular subset of patients, that they need to be informed about what the risks are and think about their role as healthcare workers, not just for themselves, but also for their families who may be exposed, but also for their patients. And then For others, it may be a question of not valuing the vaccine because they feel like COVID now is just like any other respiratory tract infection and they don't feel that they are going to have a severe course anyway. So I think that's really the perspective that I'm able to share for the moment.
Thank you, Professor Anna. Professor Zul?
Yeah, we're in the same boat, I think. We also have got no COVID vaccine now. I don't understand why actually, but then we don't have it now. And I agree with, because a lot of adverse events have been highlighted in the press as well as in social media. People are actually shying away from messenger RNA vaccines. And that may be true, may not be true, but we have to see what happens in the future. I hear that Pfizer is also coming up with a messenger RNA influenza vaccine. So we just have to see how that goes.
Okay. Thank you very much. Let's move on to the fifth question. I think Professor Zul has already shared with us their experiences on vaccine acceptance and the factors that may cause vaccine hesitancy and the success stories and so on. So may we hear from our other two speakers regarding factors influencing vaccine acceptances and identify factors causing hesitancy. And maybe you can share also success stories and how you are addressing vaccine hesitancy in your country. Thank you. Professor Anna and Professor Daniel Chu.
Hi, Dr. Josie. Maybe I can go first. So I think for the Philippines, our challenge is really less of acceptance and more of logistical considerations. Because I work in a setting where I meet a lot of families who source their vaccines from public health. And when I ask them whether they have any issues with being vaccinated, most of the time the answer is no. But what they share is, oh, but I went to the center and there's no so and so vaccine. Or the line was so long, I was going to miss work and so I couldn't stay. Or bringing my child to the vaccination center means that I have to take a day off from work, and that's very difficult for me. So those are very real concerns that I feel we need to address, on top of course, making sure that parents are well informed and that their questions are valued and addressed. So with respect to those last two aspects, again, referencing the experiences that we had with the pandemic, many people started off with this mindset, now I'm never going to get vaccinated. I don't want to. It's untested. It's not safe, and so on and so forth. And it was very difficult to actually say for certain that this vaccine was safe and going to be effective because we really had very limited experience with it. But being able to communicate what we knew from the scientific perspective and sharing the safeguards that are in place for receiving these vaccines and what to watch out for, in a respectful dialogue, I felt was very important to lead at least some people to be vaccinated. We had town halls online initially for healthcare workers because, of course, how can you deploy these healthcare workers to vaccinate when they themselves are not vaccinated and were hesitant about vaccination? So it was very worrisome for the teams, for the deployment teams, to know that many healthcare workers were not really very sure about vaccination in the first place. So we actually did these large town halls attended by thousands of healthcare workers. And prior to the start of the webinars, people were asked to fill in an online survey, which showed very low acceptance. But after the webinar, the acceptance improved. And so this was consistently seen across, I think, 4 or 5 such webinars for different healthcare professionals. And so that really, for me, illustrated the importance of listening to people, trying to find out what their concerns were, addressing them respectfully, and admitting that there are some limitations to the knowledge that we have. But in the situation that we were faced, that was really the best that could be done. And it was well received. So I feel like we can apply those same strategies for many of the issues that we're encountering at the moment in our public health setting.
Thank you, Professor Anna.
Yes, thank you,
Thank you.
Dr.
Yeah.
Anna, for the very good explanation. I think I fully agree that all the factors influencing the vaccine acceptance and the hesitancy should be country-specific. Say, in Hong Kong, that some elderly grandmothers still think that the measles is a congenital toxin. So they, rather than let the grandchildren have measles rather than the measles vaccination. So that I think that's something that we have to correct the misinformation. For RSV, the vaccine, and they think that RSV occur only in kids. But in fact, it's more detrimental for the elderly. So we have also to correct the misinformation. And for some mothers, they think that the pertussis, the whooping cough, is only for children. And they don't know that the vaccination during the late pregnancy can help. I think these factors we have to say specific to our country's acceptance. Also the shares stories that the approaches we usually use is that the engagement, empathy, education, and encouragement. As Professor Ismail has already mentioned, we never assume they are anti-vax, and they will should be empathetic and understand their concern and they clarify their misconception and misinformation. You say that we encourage them to know more, and we give the education material for them. Some of them might not believe in the local recommendation. We introduce them to international resources so that they can be convinced. Certainly, we have to encourage them to open the discussion, the dialogue, and this can help and have help in our cases.
Thank you so much, Dr. Chu. Gillian?
Thank you. So there's one more question. Because in the interest of time, I think we will answer the last question, which is addressed to all 3 speakers. So first of all, this participant, Dr. Lee, really appreciate all the talks by the speakers. He would like to know, compared with the West, he thinks that the vaccine uptake in Asia is still fairly good. So you would like to know about the vaccine hesitancy rate in each of the country or area. Maybe Dr. Chu, maybe you answer first.
Thank you. For I'd rather talk on the vaccine coverage rate rather than the hesitance rate. It depends on the individual vaccines, whether they are recommended in the government program, and also whether they are funded by the government, and also the acceptability. Say for the Hong Kong immunization for children program, the coverage rate is very high. For the BCG, hepatitis B, and also the diphtheria, pertussis, the Pentavax, and all the pneumococcal, their coverage is over 95%. So for school children, very good. And also for the HPV, as I mentioned, is very good for those, they're on the primary 5 and 6. For the so-called additional vaccine, as Professor Ismail mentioned, the coverage depends on whether they are needed. Say in the Hong Kong, the meningococcal vaccine is not recommended as in the program. as by the government, because the need for us that is not that high. The prevalence rate is only less than the one in per 10,000. So the need is not high, and the side effect is that the potential side effect is almost a balance. So the coverage rate is not that high, but actually we don't need to have a high coverage at this time. But for the other vaccines, we like to have a higher coverage. Is for the elderly vaccines. For the elderly, the vaccination pneumococcal and might be RSV, and these are very important vaccines in now and in the future. So we like to say that the coverage rate at the pneumococcal is around 50% only now, and like to encourage more. But for say that the RSV, when you need to pay, then the coverage rate might be probably lower.
Thank you, Daniel. So how about Anna? How about the vaccine hesitancy rate in Philippines?
So I'll follow Professor Chu's lead and say I'd rather discuss vaccine coverage. It's really very difficult to address the question of what is the vaccine hesitancy rate. Although there are studies that look specifically in the Philippines, and documented a drop from 95 to something like 30+% in the span of 3 years between 2015 to 2018, specifically related to our dengue vaccine controversy. I'd like to refer this question once again to the map that I showed earlier, where the studies done by the team of Professor Larson documented some vaccine confidence rates in certain parts of the world. So I'll quickly share if I can open the slide here. So just you can have an idea of what the map looks like here. So you can see this particular map in the website of the Vaccine Confidence Project. This is the website. So you might want to take a look at that so that you can see if there's specific information that you can review.
Thank you, Anna. And may I call on now Professor Lilian Wong to give us the closing remarks.
You haven't asked mine.
I'm sorry. I'm sorry. My friend.
Yeah, well, vaccine hesitancy. We actually, the Ministry of Health has this thing that all of their health clinics, whenever a patient says they refuse vaccination, the patient is then referred up to the medical officer, and then it goes up to the family medicine specialist, and then it goes up to the medical officer in charge. So when they've gone through these 3 stages, and the parents still say they don't want, then he is recorded as a vaccine refusal. And that vaccine refusal, and this is throughout the whole country, right? They have the protocol. So and since I work very closely with the Ministry of Health, I get their data, and that data is very telling because the rate is about 1 to 2% roughly. But and what was most important is they asked why they were not keen on vaccination. Now, the reasons are very, very telling, because before COVID vaccines, before the pandemic, most of the refusals was because of religious reasons, because it's not halal and all that. And the second after that was because of belief in naturopathy and because of belief in traditional medicine. This was before 2020, 2019. Now, after 2020, it was very clear. After 2019, the halal haram issue, the religious issues remained the same. But what changed was the other aspect, the other side of it. The belief in naturopathy and all that became much less. And what replaced it was actually adverse events. So something that we in the past were not very concerned about suddenly became a big issue after the COVID vaccination. This is something that we may need to think about, the effect of one vaccine, just like in the Philippines, the effect of one dengue vaccine causing all other vaccines coming down. So the same thing is in our country as well. Now, what's the question asked was, what's the rate or the incidence? It's about 1 to 2% in the number. It's very small actually. Thank you. Now you can end, Josie.
Thank you very much. I think I would like, because of time, and I would like really to conclude the section. But I think you all agree with me in the past 2 hours. I think we have a very fruitful section with very experienced speakers talking about the important topic on vaccine hesitancy, which I think is a long-lasting problem, but with very important public health as well as infectious control kind of impacts. I think in the past 2 hours, I think our speakers share with us about, like in Hong Kong, how our local government have different measures to promote vaccination, which we have a quite high of the vaccine coverage rate, especially in children. And also, the speaker at the end has shared with us, how to use scientific base, remember the confidence of the patient, the competence, and also the convenience, which also can affect the vaccine pick-up. And I would really like her statement at the end, that saying that we never assume people what they think, but they can always change. And finally, Sue has given us a lot of very good initiative that he has done in Malaysia, and all his fellow pediatrician has been done to promote the vaccinations. I think we all remember that the SDGs, the Sustainable Development Goals, we have 17 SDGs, which started in 2015, should be end in 2030. That means a few years away. In one of the the SDG 3, number 3, the goal 3, is good health and well-being. And in the target 3B, actually mentioned about how to promote research and also, the evidence for and support vaccination as well as medications. So it means that there's a lot to be done, how we should promote vaccination to our children and also to the public as well as the parents. And I think APPA, to start with, we call APPA, was set up in 1974. So that's why last year, 2024, we have our 50th anniversary in Cebu, Philippines. I think APPA with the goal that we promote, child health, to, encourage research, and also and have this kind of knowledge transfer and also sharing among our member society in the Asia Pacific region. And throughout the time, I think APPA have a lot of meetings, and I'm sure this webinar, APPA webinar, was initiated by Jocelyn, our president, and also Sue, the Secretary General, under their capable, leadership. We have this good webinars, and I'm sure there are more good webinars to come. And as Sue just mentioned, that there will be a Asian Vaccine conference in October in Malaysia, and I think there will be another 14 World Congress on infectious disease in Thailand in October as well. So just give some promotion for APPA. So I think at the end, I would like to conclude. First of all, I greatly appreciate all the 3 speakers for their excellent talks. And also, I would like to thank you, the IT team from the Philippine Society Pediatrics, for the support for the beautiful poster, and also APPA's Secretariat, Pharaoh, for us to disseminate all those information to our member societies. And also, I think, last but not the least, I would like to really thank this platform, this webinar platform is from the Child Sim Talk of the Hong Kong Pediatric Society, supported by Dr. Bill Chen, who is the mastermind today behind the scene to support all this IT kind of support and also arrangement so that we can have this successful webinar. So I think I would like to conclude it and hope every one of you enjoy this webinar and hope you have an enjoyable time, Sunday evening in the rest. Okay, thank you. Jocelyn, anything you want to add?